evening, everybody. I will take you through, as I said, the enhanced recovery after surgery, the anesthetic management. And what I will try and take you through is try and get you a kind of a template as to what you can use, especially for students when you are trying to get in for, you face any question that you get as to anesthetic management of a patient undergoing X surgery, Y procedure, or D operation. So I think this serves as a very good template. So what essentially is this ERAS? And ERAS has come as a question. It is asked during practicals. It is asked in theory. So what exactly is ERAS is nothing but enhanced recovery after surgery. Some people also call it the enhanced recovery pathways. And this came out with a publication from Kellett in 2008, which essentially is nothing but multimodal, multidisciplinary fast-track surgery. Right now, we kind of associate this with things which can fasten recovery after various type of surgical procedures. And these protocols that you have are evidence-based therapeutic interventions, and this starts in the preoperative period and goes on till the postoperative period. And you'll find a lot of these protocols and guidelines which come in, and these keep evolving. And so the last that I could go through were ones that were published in 2019. And a good friend of mine, Dr. Girish Joshi, sitting in Texas, has been one of the key proponents of these ERAS pathways. So what does ERAS or ERP try to do? It is they're trying to do a standardized care, and this standardized care can be taken over through all institutions, so that we then know, if you get them through these protocol, that do you actually improve the outcomes. They take into account that the surgery is a huge kind of an insult to the patient's physiology. So there is a huge surgical stress response, and there is postoperative pain. And if you can manage these two effectively, you can reduce complication and improve the outcomes, and which essentially leads to decreasing the hospital length of stay and expedite the recovery following a lot of elective procedures. So this is the ethos of ERAS. Is ERAS anything different than what we used to do 10 years back, 15 years back, 20 years back? It essentially is not. And this is what we keep telling people, that the principles of perioperative care for major surgical procedures, particularly the preoperative and intraoperative management, remains the same. It's only that few things have been brought into limelight. Some things have been highlighted. Some things have been figured out, that which was done routinely, kind of without much of evidence, is not been doing good to patients, and it's time to abandon that. And there are certain things that you do for certain procedures. So there are few procedure specific variations. What we will go through today is not very procedure specific, but a very generic one. This is how the ERAS, I think, I came out, I talked about in the early 90s that it came out, and they had a huge number of elements that were part of the protocol. Till it's around 2001, they figured out that not all of these are equally weighted, and there is not enough evidence to suggest that they improve postoperative recovery and decrease complications. So the ERAS elements, and these keep changing. And the one that I could find in 2018 were, I think, few of these that I have just put in, and we will go through this as we go through the evening. One is no mechanical bowel preparation. I know that as an anesthetist, we are not much involved with this, but it is one of the elements, in a huge element. I think we talked about myths about feeding and fasting, and this is what we learned from ERAS, that you allow a light meal up to 6 hours and consume clear fluids, including the much talked about oral carbohydrate drink until 2 hours prior to the initiation of anesthesia. Pre-medications, and this is, I think, a huge area that I have learned, from eras after following eras is that pre-medications is not the classic pre-medications that we learned in our residency days, but this pre-medications would be uh, pain medications, and classically the non-steroidal drugs, acetaminophen, NSAIDs prior to surgery, and possibly antiemetics that you start prior to surgery. Intraoperatively, maintenance of normothermia, euvolemia, which I think intuitively everybody does.